Hi everyone, welcome to MedGoto. This is going to be our first discussion on USMLE series lecture or discussion that we're going to be going over, especially for people who are studying for the United States Medical Licensing Exam Step 1. I believe these topics we're going to be discussing is going to definitely help you. Like I always tell students, make sure you also do your own research to see what works best for you. So the first topic that we're going to be covering, so we're going to start with general pathology, and then we're going to cover different sections on the general pathology. So the first topic we're going to be talking about is going to be cellular adaptation. Cellular adaptation. And don't forget, if you are yet to subscribe to the channel, don't forget to subscribe to the channel. As I promised, we're going to be putting out a lot of videos in relation to USMLE series, other different topics that will definitely help us. So starting with cellular adaptation, when we look at our body or our organ, one thing we can say about them is that they're in a constant homeostasis with the physiologic stress that is being placed on them, right? So the cells are in constant homeostasis, right? With the physiologic stress, right? So they are able to undo all this stress that's been placed on them. Right? And if there's any changes in this stress, maybe the stress is increased or the stress is decreased, this can lead to what we call adaptation. So the cell have to look for a way to be able to adjust to this new stress level, right? So any changes in the stress, right, either increase or decrease, right, will lead to what we call growth adaptation. And then we're going to be talking about these different types of adaptation. We're going to be covering different types. And then when we look at this adaptation, they are usually something that is reversible. Right? So they are usually like a reversible functional and a structural response to severe stress, right? So for instance, let's say this is our cell, right? So let's just assume this is our cell, right? So if this cell is exposed to a particular stimuli, right? In this case, maybe some severe stress, right? So this cell, right, is going to, it can adapt, right, to the stress, right, through different way, maybe by getting more bigger in size or increasing in number, or maybe even changing from one cell to another type of cell, right? So which is what we call the cellular adaptation, right? And of course, if the, and like I mentioned, this cellular adaptation, most of the time they are reversible. So once you remove the stress, then the cell will go back to the normal state that they were before. And if this stress is too much, right? So for instance, let's say the stress is too much, that can lead to injury to the cell, right? So that can injure the cell, right? So injury to the cell. So if there's too much stress, right? And if there's injury to the cell, right? The cell could be repaired, so you can repair the cell. And if you repair the cell and the stress is removed, right? So the cell will go back to its usual state, right? And of course, if the injury is too much, right, that will actually lead to it can lead to what we call cell death. So it can kill the cell, right? And there are two major ways that cell can die, right, which we want to talk about later. The cell can die by maybe necrosis, right? Or it can die by apoptosis. And of course, we're going to cover all these topics later, right? And like I mentioned earlier, the essence of cellular adaptation is basically to establish a new steady state that could allow them to survive and also continue to function. So in other words, they can continue to deal with the stress, right? So they establish a new steady state that allowed them to be able to survive and continue to function. So having said that, so just in summary, so we have a cell, right, which is normally in a homeostasis with the regular physiologic stress. But if the stress is too much, right, or if there's any changes in the stress, then the cell has to adjust to that new stress level, right? And that adjustment is what we call cellular adaptation. And that cellular adaptation is usually reversible once you remove those unnecessary stress, right? And if the stress is too much, that could lead to injury to those cells, right? And then from the injury, they can recover from it, right, by repair, right? So they recover and they go back to their usual state. And then if the injury is too much, that could lead to cell death. So the cell can die, either by necrosis or by apoptosis. So now let's now go to different types of cellular adaptation, right? So types of cellular adaptation. So the first one we're going to talk about under cellular adaptation is hypertrophy. So when we talk about hypertrophy, right? So hyper means size, right? And so when we say hypertrophy, right? So it means increase in the size of the cell, right? So hypertrophy is increase in the size of the cell. So hyper increase trophy, right? Size. So increase in the size of the cell. And then this is due because there is a new stress level on the cell. And as a result of that, for the cell to be able to deal with that new level of stress, they have to increase in size, right? So usually due to an underlying stimuli, right? And this stimuli that is being placed, that is causing stress on the cell, will activate the gene. So we need to cause gene activation. So we need to cause gene activation, and this will lead to increase in protein synthesis, right? And organelle production. And ultimately, the evidence of this will be increase in the cell size, right? And here, the stimuli most of the time for hypertrophy is usually due to increase in work overload, right? So increase work overload. So if you put in a lot of work, if you are putting a lot of work on the cell, that will make the cell to get bigger. So increase in work overload, that's usually the stimuli. So let's look at some classic example of hypertrophy. So we want to start with, example. So I want to start with the cardiac system. Right? For example, we're going to start with the cardiac muscle. So if you look at our diagram by the side there, you're going to see me using this diagram a lot. And kind of like give us like a visual representation of what's going on with the heart, right? So here is going to be our SVC, superior vena cava, IVC, right? They bring blood into the right atrium. From the right atrium, right? They go into the left, into the right ventricle, and then from there they go into the pulmonary artery, right? And there's an important valve here, which is pulmonary valve, right? Which is right here. And here we have and they're going to go into the lungs for oxygenation. They come back to the pulmonary vein, into the left atrium, left ventricle, and then they leave through the aortic valve into the aorta. So if somebody have hypertension, so this time around we're talking about systemic hypertension. Systemic hypertension. So if somebody have long-standing hypertension that is uncontrolled, right? So just imagine the blood pressure here is very high, right? Normally in the left ventricle, the pressure here is usually 130 over 10, right? So that means in systole is going to be 130, and the diastole is going to be 10. And in the aorta, usually something like 130 over 90, right? So if somebody has systemic blood hypertension, so because of the increased blood pressure, so let's say this patient blood pressure now is something like maybe let's say 180, right, over 110. So as a result of that, that will increase the afterload, right? So that will increase the left ventricular afterload. And then because of the increased afterload, right, so the ventricle has to be contracting against very high pressure. And that can lead to, and then for the ventricle to deal with that, right, so they have to increase the size of the muscle. So that will lead to gene activation, and that will cause left ventricular hypertrophy, right? So systemic hypertension leading to left ventricular hypertrophy. And the left ventricular hypertrophy, as you guys know, is the most common complication, right? Most common complication of somebody who has a long-standing hypertension, right? So somebody who has a long-standing hypertension, left ventricular hypertrophy is the most common complication. And what type of heart sound are we going to hear in this patient? S4, right? So you're going to hear S4 heart sound, right? And remember, S4 heart sound is always pathology, right? So anytime you hear S4, it's pathology. And it's usually due to decrease in the compliance of the left ventricle, which we have to cover when we get to cardiovascular. Another example is if somebody have aortic stenosis, right? So with aortic stenosis, if the aortic valve is stenosed, right? So same thing, that will increase the afterload, right? And that will also lead to left ventricular hypertrophy. So that will lead to left ventricular hypertrophy. Moving on, another example of hypertrophy is going to be on the right side, right? So if somebody have pulmonary hypertension, right? So pulmonary hypertension. So with pulmonary hypertension, so that means the pressure in the pulmonary system is increased. So as a result of that, that will increase the afterload in the pulmonary system. So just imagine the pressure has increased. So that means the right ventricle will be contracted against high pressure, and that can lead to right ventricular hypertrophy, right? So that will cause gene activation because of the increase in because of the increase in workload, right? So that will cause gene activation, and that will cause right ventricular hypertrophy, right? And usually, whenever I'm reading one of the buzzwords, when you're reading the question, to know if you are dealing with pulmonary hypertension, they will tell you somebody who's having progressive dyspnea, right? So somebody who's having progressive dyspnea, right? And then they mention that the patient has a loud P2, right? So when you see this together, progressive dyspnea with loud P2, always think of pulmonary hypertension, right? Always think of pulmonary hypertension. And of course, if the pressure is very high, right, that will also cause tricuspid patient can start having things like tricuspid regurgitation, right? Which is going to be like creating like a holosystolic murmur. That's in that area. Another cause of right ventricular hypertrophy could be if somebody has pulmonary stenosis. So if there's a pulmonary stenosis, if the valve is stenosed, right, that could also lead to right ventricular hypertrophy because of the same reason. So because of the increased afterload that's causing pulmonary stenosis. Can somebody give me an example of a condition that can cause pulmonary stenosis? Because it's a very rare condition, it's not something that we see a lot. If you say carcinoid syndrome, very good, right? So carcinoid tumor. If somebody have a carcinoid tumor, right, especially if it has metastasized to the liver, right, those secretion can increase collagen production, and that could cause some pulmonary stenosis. So with carcinoid tumor, they usually have tips, tricuspid insufficiency, and a pulmonic stenosis. Moving on, so that's our cardiac muscle. Another example of hypertrophy is going to be related to skeletal muscle. Skeletal muscle. So, which is normally seen in a muscle builder. Right? So, if somebody is going to the gym every day, right, putting a lot of weights on their muscle, right? So those weights that they are putting on the muscle, that could cause gene activation, and that can lead to skeletal muscle hypertrophy. Somebody that is working on their biceps, right? So they keep putting pressure on the bicep every day, and that can lead to bicep hypertrophy. So moving on to the next one is going to be smooth muscle. Smooth muscle. A classic example of where we can have like a smooth muscle hypertrophy is going to be in pregnancy. Remember, in pregnancy, there's increase in hormone production, right? The placenta is producing a lot of hormone, right? And one of them is estrogen. And this estrogen, right, can induce uterine muscle hypertrophy, right? And to be able to accommodate the growing fetus. So that would be another example. The next example that we also have to be aware of is surgical removal of kidney. So if you remove one kidney, right, the other kidney is going to undergo what we call compensatory hypertrophy, right? Because that other kidney, right, is now doing more work, right? And then we said that the stimuli for hypertrophy is usually increase in workload. So the remaining kidney will undergo compensatory hypertrophy to be able to cope with the new workload, right? And the last example is cell enlargement that we see in CMV infection. So with CMV infection, what we see is that there's increased ion uptake into the cytoplasm of the cell, and as a result of that, we can also see cell hypertrophy. So these are a couple of examples of hypertrophy that they are well tested on the exam that we need to be aware of. So before we move on to talk about the next adaptation, another example of cellular adaptation, I quickly want to talk about cell cycle phase, right? And this is the reason why this is very important is that this can give us an idea of what the cell is capable of as a result of change in stress to those cells, right? So I want to just quickly talk about cell cycle basis. Right? Although we're going to cover it when we get to biochemistry, so yeah, just like a little bit of introduction. So when you look at the cell cycle, right, for any cell to divide, right, in our body, those cells have to go through the cell cycle, right? So for them, if for instance, for a cell to divide into two, they need to go through the cell cycle, right? And the cell cycle is divided into different parts, right? So we have what we call the geophase. So there's a geophase. Let me use the black. So there's a geophase. There's G1 phase, right? So we have the G1 phase. Next. And we have the S phase. And during S phase is when the DNA synthesis takes place. DNA synthesis. And after the S phase, we have the G phase, right? Going to be our G2 phase. And after the G phase, which is the G2, then we have the M phase, which is when the cell divides into two, which is our mitosis. Right? But like I said, we're going to go through this more in detail during biochemistry, right? So looking at the cell cycle, so we have the GO phase, right? Which is usually the resting phase, right? So GO phase is kind of like a resting phase, right? And then if a cell needs to divide, they need to go to the G1, right? And the G1 is when we make sure, right, there's no mutation, the cell is okay to go into the S phase, right, and start the process of cell division, cellular division, right? And then this G1 to S phase, right, is tightly regulated. So we have some important gene that are regulating this phase, right? Example include our P53 and also the RB gene, right? So RB gene and P53, those guys are helping us to regulate this area because you don't want any mutation to move from the G1 to the S phase. So we have three main cell types, right? So cell types, so there are three main cell types, right? Number one is what we call the permanent cells. We call them permanent cells, right? And what does that mean? So these permanent cells, they are always in the GO phase, right? So they are always in the GO phase. They don't go into the cell cycle to divide. So you don't see permanent cell going to the G1 and going to the S phase or G2 phase to divide. So they are permanent cells. So that's why we refer them to as permanent cells, right? So those cells remain in the GO phase, right? And if there's a need for them to regenerate, they have to regenerate from the stem cells. So they need to regenerate from the stem cells. An example of those permanent cells, right, include the cardiac muscle, skeletal muscle, right? So cardiac muscle, skeletal, and also neurons is also there. The neurons and the RBC. So these are a couple of examples. And that's why when we talk about cardiac muscle and skeletal muscle, that's why those cells, they cannot divide. So because they cannot divide, they cannot undergo hyperplasia, which we have to talk about in a second. They can only undergo hypertrophy. They can only increase in size because they cannot divide. Right? So that's why you know to see us saying like cardiac hyperplasia or cardiac muscle hyperplasia or skeletal muscle hyperplasia because they can only increase in size, they cannot divide. And the reason being because they are permanent cells, they are always in the GO, they don't divide. So the second type of cell, and also another thing to also notice that if you are giving, like in the case of cancer, right? Most of the cancer medication, most of the chemo medication, which we have to talk about in a second, they normally target the cell cycle, right? So that means they can only target things that are moving through the cell cycle that are rapidly dividing. So that's why sometimes they are less likely to affect the cardiac or skeletal muscle. So they have less effect on the cardiac and the skeletal muscle. So moving on to the next one. So we spoke about permanent cells. The next one is going to be our stable cell, the stable cells. And the stable cells, we also call them quiescent cells, right? We also call them quiescent cells, so stable cells. So these stable cells, right, also they are always in the GO phase, right? So they are always in the GO phase, but if something stimulates them, like growth factor, right? So if growth factor stimulate them, they can move, or if there's any injury to them, right, and they want to repair, they can move from GO phase and now move to G1 phase and then go through the cell cycle and divide. So stable cells, they are always in the GO phase, but if anything stimulates them like growth factor, that could make them to go into the cell cycle and then divide. So that's why we call them stable cells, right? And then that's why when a classic example of those cells include things like hepatocytes, lymphocytes is also there, and then periosteal cells, right? So these cells are stable cells. And that's why if somebody have a injury to their liver, right? For instance, let's say for no reason there is a damage to their liver, they have to take out part of their liver. Couple of months later, you can see that the liver will have grown back to the regular size. Why? Because they have the ability to be able to divide, right? And then most of these stable cells, right, they can undergo both hyperplasia, right, because they can divide, and they can also increase in size. So they can also undergo hypertrophy. So they can undergo hyperplasia and hypertrophy. And the last type of cell that we're going to talk about, which is the third one, are what we call the Labile cells. Right? So these Labile cells, they are always in the cell cycle. They don't go to GO at all. They don't go to GO phase. So they are always in the cell cycle, constantly dividing. So they are constantly dividing in the cell cycle. So they don't go to GO phase at all. And an example of those cells include things that are constantly divided, cells that are constantly being replenished in our body, right? Bone marrow, right? Because we need to be making blood, right? Every time, so making blood cells, right? So bone marrow is there. Our gut epithelium is also there. Our skin is also part of this, right? Germ cells is also part of this. Hair follicle is also part of it. So because these cells, they are constantly dividing, they're in the cell cycle. So that's why these cells, they can only undergo what? Hyperplasia. So they can divide and to be able to increase in numbers, right? Because they are constant, they have that potential to be able to divide, right? And then these cells, because they are always in the cell cycle constantly dividing, these cells are most commonly affected by what? By chemotherapy. So when you put patient on chemotherapy, these are the cells that you're expecting to be targeted, that are to be affected by the chemotherapy. For instance, if a patient is on chemotherapy, you can see those patients, they can develop bone marrow suppression, so they can develop anemia, their platelet can go down, they can start bleeding, their WBC can go down, right? So they can easily get infection, right? The gut epithelium could be affected, so they can start developing diarrhea. So that's why patients on chemotherapy, they do get diarrhea. Skin changes, right? Infertility, and also a very important question, if you have somebody that is a young female, right, of a reproductive age, newly diagnosed with a cancer and needs to start chemotherapy, you need to refer them to fertility specialists. So they need to see a fertility specialist, because as soon as they start chemotherapy, that will affect their germ cells, right? And also hair follicles, so they can start losing their hair, all the stuff, right? So these are things that we can see because they are Labile cells. So the reason I'm talking about this under cellular adaptation is to have an idea of if these cells are exposed to any particular stress, what are they capable of doing? So permanent cells, particularly the cardiac muscle, skeletal muscle, they have that ability to undergo hypertrophy. They cannot increase in number, but they can increase in size. Stable cells have the ability to increase in number and also increase in size, and the Labile cells have the ability to increase in numbers. So having said that, we're going to move on to the next type of cellular adaptation. It's going to be the second one, and that's hyperplasia. Hyperplasia. So what's hyperplasia? So hyperplasia is increase in the number. So here is number, not size. Increase in number of cells in the organ or tissue. So increase in the number. And a note, something to also remember, that sometimes hyperplasia and hypertrophy, they can occur together. So both hyperplasia and hypertrophy, they can occur together. And like we mentioned earlier, the labile cells and the stable cells are the ones that have the ability to be able to increase in what? They have the ability to be able to increase in number, right? So like we mentioned the labile cells and the stable cells, right? So both of them can undergo hyperplasia. The other thing that's also important for us to remember before we talk about examples of hyperplasia is that whenever there is hyperplasia can increase the risk for dysplasia. So dysplasia is abnormal cells, right? So hyperplasia can increase the risk for dysplasia, which is abnormal cell, and this dysplasia can lead to cancer, right? Can lead to neoplasm or neoplasia, which is what we call cancer, right? But one of the exceptions to that rule that we need to remember for the purpose of the exam that they can ask us is in the case of benign prostatic hyperplasia. So benign prostatic hyperplasia is not, and this is very important because they can ask, it's not a risk factor for prostate cancer. So this hyperplasia will not lead to prostate cancer. So that's important for us to know. It's something they can ask on the exam. So let's now look at different examples of hyperplasia. So the first one, we're going to group them based on hormonal stimulation, chronic irritation, chemical imbalance, stimulating antibody, and infection. Right? So let's start with increased hormonal stimulation. So the first hormone we're going to talk about is estrogen. Right? So if there's increased estrogen, right? This can stimulate in a female, this can stimulate the endometrium, right? And if it's stimulating the endometrium, that can lead to endometrial hyperplasia. That can lead to endometrial hyperplasia. And this can be seen if somebody who have ovarian tumor, right, that is producing a lot of estrogen, or somebody who have polycystic ovarian syndrome. Those patients also tend to have high estrogen, and that can lead to endometrial hyperplasia. And like we mentioned earlier, endometrial hyperplasia, this can lead to endometrial cancer, right? And that's why patients who have PCOS, polycystic ovarian syndrome, we treat them because we don't want them to develop endometrial cancer, right? And a classic history for endometrial cancer for the exam, you always want to look for postmenopausal vaginal bleeding. So anytime you've seen a question of somebody who is postmenopausal, right? So postmenopausal vaginal bleeding, you always want to think of endometrial cancer, right? And in that case, you do your endometrial biopsy to be able to confirm your diagnosis. Right? So that's one of the examples of hormonal stimulation. Another example of hormonal stimulation is DHT, right? Dihydrotestosterone. So in a male, this dihydrotestosterone can stimulate the prostate, right? And if it stimulates the prostate, that can lead to benign prostatic hyperplasia. But remember, we said that this is not a risk factor for cancer. This does not lead to cancer. Yes, very important to remember. So that's an example of hormonal stimulation. Right? Moving on, another one that we can also add to it is what we see in a congenital adrenal hyperplasia. So this is also due to hormonal stimulation, right? In patients who have congenital adrenal hyperplasia, because of the enzyme deficiency in the adrenal gland, so as a result of that, there is a decrease in cortisol production, less negative feedback to the hypothalamus and pituitary. So as a result of that, there's increase in ACTH production. And this ACTH stimulates both of the adrenal glands continuously, and that creates hyperplasia. So increased ACTH stimulating the adrenal gland. And then when we talk about endocrine, we're going to see a lot of more examples of hormonal stimulation leading to hyperplasia. So another example of hyperplasia apart from hormonal stimulation would be chronic irritation. Chronic irritation. And a chronic irritation example, you can talk about smoking, right? Or patient who have asthma, constant exposure to the allergen that is being irritating their asthma, that is exacerbating their asthma. So either of them, either smoking or asthma, right? Recurrent exacerbation can lead to bronchial. So this can stimulate the bronchial mucous gland, and the mucous gland can lead to we can develop hyperplasia of it. Right? So hyperplasia of the mucous gland, right? And then there's when we get to when we talk about COPD, chronic bronchitis, when we get to respiratory system, there's something that we can actually use to evaluate the size of how big the mucous gland is, right? Which is what they call the Reed index, right? So we're going to talk about this when we get to respiratory system. Another example of chronic irritation will be in the case of atopic dermatitis. Right? So in patients with atopic dermatitis, maybe because there's something particular that they are allergic to, so they keep scratching their skin. So that constant scratching of the skin can lead to epidermal hyperplasia. So constant scratching, skin scratching, right? That can lead to epidermal or epidermis hyperplasia. So that's also another example of chronic irritation. And the last example of chronic irritation that we can also add to that is somebody that is drinking a lot of alcohol, excessive drinking. So this can lead to, this can damage the liver, cause irritation in the liver, and that can lead to production of regenerative nodules, right, in the liver. And then don't forget in liver cirrhosis. And these regenerative nodules, right, they carry the risk for hepatocellular carcinoma. So this patient with liver cirrhosis, we need to monitor them closely for hepatocellular carcinoma because they are at increased risk for hepatocellular carcinoma. And just a side question, anybody know what cell in the liver, in the hepatocytes, is responsible for these regenerative nodules? I2 cells, right? I2 cells. Which we can also call it stellate cells, right? And these cells normally store vitamin A. So they normally help to store vitamin A. But of course, if there's any chronic irritation or damage to the liver, so what happens is that this I2 cell will start to make fibroblasts, and that will lead to formation of those regenerative nodules, right? So we spoke about increased hormonal stimulation, right? We spoke about chronic irritation. The next one is chemical imbalance. Chemical imbalance. Under chemical imbalance, right? Example is if somebody has things like hypocalcemia. So if the calcium is low, right, the body wants to try to increase the calcium back to normal, right? And then one of the hormones that regulate calcium is parathyroid hormone, right? So because of this hypocalcemia will stimulate the parathyroid gland, right? Parathyroid gland to produce parathyroid hormone, right? So that the parathyroid hormone, if you guys remember, the function of the parathyroid hormone, right, at the proximal convoluted tubule, right, is going to help to increase excretion of phosphates. So it's going to trash phosphates. But at the distal convoluted tubule, it's going to help to increase reabsorption of calcium back to the body. So it's going to increase calcium back to the body, right? So increase excretion of phosphorus, right? But increase reabsorption of calcium, right? So as a result of that, that can lead to parathyroid gland hyperplasia. Another example of chemical imbalance would be iodine deficiency or excess. So either of the two, either too much or too little. And of course, that can also lead to thyroid gland enlargement. So those patients can develop what we call goiter. So another example of hyperplasia is stimulating antibodies. An example of this stimulating antibody is classically seen in patients who have Graves' disease. And what's going on in Graves' disease? So in Graves' disease, these patients, they are making antibody, right? They are making what they call TSI, which is thyroid stimulating immunoglobulin. And then remember, this thyroid stimulating immunoglobulin is IgG. Very important, right? So this thyroid stimulating immunoglobulin is going to go and bind, because on the thyroid gland, there is a receptor for TSH there. So when TSH is released from the pituitary, this TSH can come and bind to the TSH receptor on the thyroid gland and stimulate the thyroid gland to start making thyroid hormone, right? But in Graves' disease, they are making antibody against this receptor. So this antibody has the ability to stimulate this receptor. And then by stimulating this receptor, right, this thyroid gland is going to start producing more thyroid hormone. And then because of those excess stimulation, there's going to be increase in this in the number of cells there. So the thyroid gland could undergo what? Hyperplasia, right? And that's why in patients who have Graves' disease, you're going to see that symmetry enlargement of their thyroid gland, right? So symmetry enlargement of their thyroid gland, they can have like apoptosis of their eyes and other findings that we see there. So this is an example of stimulating antibody. And the last example I'm going to talk about is going to be viral infections. The viral infection. A classic example of viral infection that could cause hyperplasia is HPV, right? Human papilloma virus, right? So this virus can stimulate the epidermis, right? And that could lead to epidermal hyperplasia. And of course, with the epidermal hyperplasia, right, they want to develop and manifest as common warts, right, or genital warts that we can see in them. And then when we get to reproduction, we're going to talk about different genes that this virus can produce and the way they affect the cell cycle to be able to increase cellular growth, right? So like E6, E7, right? And the E6, right, which can inhibit the P53, and the E7, the product from the E7 can inhibit the RB gene. And by inhibiting those guys, those guys are the ones that control the cell cycle. So by inhibiting them, then there is an uninhibited cell division, right? And that leads to epidermal hyperplasia. So we've spoke about hypertrophy, and we also spoke about hyperplasia. So the next one we're going to talk about is going to be the third one we're going to talk about is going to be metaplasia. So metaplasia is going to be the next one. And then before we go to metaplasia, I'm going to ask us to take a break, and then once we come back, we continue.